Welcome to MicroMed education students. Today we are going to discuss the part 2 of the malaria, that is laboratory diagnosis of malaria. Before proceeding to this lecture, please stay till the end because in this lecture we are going to discuss the various frequently asked questions that will be asked in your practical exam, because in theory you will definitely get a laboratory diagnosis at short note or as a part of the 10 marks question. So we have already known there 5 Plasmodium species, that is P. vivax, P. falciparum, P. malariae, P. ovale and P. knowlesi, among which the most severe one is P. falciparum. Laboratory diagnosis, student, you have to understand this is a parasite, and the laboratory test here is the gold standard one is the peripheral blood smear examination, that is a thick smear and thin smear as well as quantitative Buffy code. Then we have a rapid diagnostic test, culture, basically for research purpose, and molecular diagnostics. The serological test is banned because diagnosis based on the antibody detection cannot rule out present infection because the antibodies can persist in the past clinical cure. So Government of India has banned this antibody detection test for malarial diagnosis. The peripheral smear examination, that is the gold standard, it has 2 types of smear, thick smear and the thin smear. Understand, thick smear is for the detection and thin smear is for the speciation. Thick smear is 40 times more sensitive than the thin smear. The detection limit is only 5 to 10 parasites per microliter, and it is mainly as discussed for the diagnosis of malaria. However, thin smear, it is you have to screen through the feathery tail end and it detects more than 200 parasites per microliter for accurate speciation of the parasite, whether it is vivax, falciparum, malariae, ovale. That understand the collection of a blood should be after the height of fever paroxysms but before anti-malarial drugs, and you can stain it with any Romanowsky stain, that is Leishmania, Giemsa, Fields, Wrights or GSB. Now the most important part, how these parasites looks in their blood smear. So the most common question would be in your practical exam is what are the laboratory diagnostic tests. So first you have to mention is the thin smear, thick smear, QBC and antigen detection. Now the second one, what is the difference between the P. falciparum and P. vivax malaria as such also, or in a peripheral smear? So basically in peripheral smear, what you find, it's the trophozoite or the ring form. So there are different types, early trophozoite, late trophozoite, schizon, gametocyte, etc. These will be present in your peripheral smear. But the thing one has to understand here is how they appear. So the falciparum malaria, the ring form are multiple. The RBC would be remain in the normal size, and there is a gametocyte that is of banana shape. There will be no multiple, means the schizons is generally not present in peripheral smear. But in case of vivax, there is only RBC will be enlarged. It affects young RBC. The difference we will going to discuss in the next slide. But here you can understand there is a amoeboid form and schizon, and the gametocyte will be in round. The ecol form is also a characteristic of a P. falciparum, where the RBC is present at the edge of the the ring form is present at the edge of the RBC. So let's understand the difference. At least you should enumerate 4 to 5 difference in your Viva. So first of all, how you can understand the falciparum, the size will remain normal, but vivax it will be RBC enlarged. Falciparum affects all the ages, means there is no preference of the RBC. That's why there is a high parasitemia, and there will be sequestration of the parasite because of its pathogenesis. In case of vivax, it only affects young RBC. High parasitemia is associated with falciparum, low with the vivax. A ring form is multiple, aplic form as we discussed. Trophozoites, the sequestration would be there in vivax, that is a large amoeboid form. Schizons is present in vivax, and The gametocytes are round and crescent or banana shape in case of falciparum. Scuffner's dots are absent, however present in case of vivax. And the pigment is dark brown in falci and coarse brown in case of vivax. You have to at least remember the RBC, the preference, the schizont and gametocyte. Even this much also is easy for you to remember. Now the malariae and ovale. The malariae, there is a characteristic band form. The trophocytes stretch across the entire RBC like a solid dark band. And in case of ovale, the hallmark is enlarged but fimbriated, that is rag edge oval shaped RBC containing ring form. In QBC, basically, the blood would be taken in a capillary tube which is internally coated with the acridine orange. And after centrifugation, in the Buffy coat, you will find fluorescent as brilliant green dot that are the ring forms that are present. Even you can find a gametocytes under ultraviolet red. Now let's understand the antigen detections. So 3 antigens are there: parasite lactose dehydrogenase, aldolase and HRP2. Among this, LDH and aldolase is pan-malarial antigen. It is produced by all Plasmodium species and it is crucial for assessing the prognosis and treatment response. The detection limit is 100 parasite per microliter, and for HRP2 that is released by the P. falciparum, and here the detection limit is 40 parasite per microliter. So basically an ICT would be there, so in that a control band must be for the validity. Then pan malaria suggests malaria, but if it is for HRP2 then it is suggestive of, that is, P. falciparum. So basically the pan malaria cannot differentiate between whether it is vivax, malariae, ovale, but you can understand that it is a malaria. So let's revise all this. So for peripheral smear, the sensitivities, for thick it is 5 parasites per microliter and for thin it is 200. For RDT it is 100, but for HRP2 it is basically 40. QBC is equal, that is of high. Speciation is done in case of peripheral smear, difficult in case of RDT and QBC. Skills are experienced microbiologists or pathologists required to visualize and detect parasites, but for RDT minimal training, and even for the QBC, and the time is also 15 to 30 minutes. The drawback of peripheral smear is labor intensive expertise. QBC it is a costly instruments and false positive from the artifact, and in RDT false positive from the rheumatoid arthritis. So if you have to understand the malaria, so first of all the clinical clue, that is fever, periodicity, anemia, then even thrombocytopenia you will find in cases, and splenomegaly. Later on you have to understand whether it is benign or malignant. Malignant due to sequestration, deep organ hypoxia, altered mental status and related complication. Laboratory diagnosis required: peripheral smear, thick smear, thin smear. Then rapid diagnostic tests, these would be your serological antigen detection test, pLDH, HRP2 and aldolase, as well as quantitative Buffy coat. The differentiating points between please 5x, malariae, ovale and falciparum is from the peripheral smear examination by visualizing ring form and gametocytes. Hope student you like the video of the malaria. Please do not forget to like, share and subscribe our channel, and provide some comments also, and recommend this to your peers and colleagues. Please do not forget to learn malaria, because it is very important and will be definitely asked in your examination.